All right, good morning and welcome to the Health and Human Services Committee. My name is Senator Ben Hansen. I represent the 16th Legislative District in Washington, Burt, Cumming, and parts of Stanton counties, and I serve as chair of the Health and Human Services Committee. I would like at this time to invite the members of the committee to introduce themselves, starting on my left with Senator Ballard.
Bo Ballard, District 21, Northwest Lincoln and Northern Lancaster County.
Good morning. My name is Lynn Walz, and I represent Legislative District 15, which is Dodge County and Valley.
Good morning. I'm Brian Harden from District 48, Banner, Kimball, and Scottsbluff counties.
I'm Murph Riepe, Legislative District 12, which is Southwest Omaha and the small town of Ralston.
Also assisting the committee is our research analyst Bryson Bartels and our committee clerk Christine Campbell, and our committee pages Sophia and Ken, right? Okay, I'm looking for Ken. A few notes about the policy and procedures here. Please turn off or silence your cell phones. We will be hearing 4 bills this morning, and we'll be taking them in the order listed on the agenda outside the room. On each of the tables near the doors to the hearing room, you will find green testifier sheets. If you're planning to testify today, please fill one out and hand it to Christina when you come up to testify, or one of the pages. This will help us keep an accurate record of the hearing. If you are not testifying at the microphone but want to go on record as having a position on a bill being heard today, there are white sign-in sheets at each entrance where you may leave your name and other pertinent information. Also, I would note, if you are not testifying but have an online position comment to submit, the legislature's policy is that all comments for the record must be received by the committee by noon the day prior to the hearing. Any handouts submitted by testifiers will also be included as part of the record as exhibits. We would ask, if you do have any handouts, that you please bring 10 copies and give them to the page. We use a light system for testifying, which is right in front of you when you testify. Each testifier will have 5 minutes to testify. When you begin, the light will turn green. When the light turns yellow, that means you have 1 minute left. When the light turns red, it is time to end your testimony, and we will ask that you wrap up your final thoughts. When you come up to testify, please begin by stating your name clearly into the microphone, and then please spell both your first and last name. The hearing on each bill will begin with the introducer's opening statement. After the opening statement, we will hear from supporters of the bill, and then from those in opposition, followed by those speaking in a neutral capacity. The introducer of the bill will then be given the opportunity to make closing statements if they wish to do so. On a side note, the reading of testimony that is not your own is not allowed until previously approved. And we have a strict no prop policy in this committee. So with that, we will begin today's hearing with LB 12 and welcome Senator Blood. Welcome.
Thank you. So good morning, Chair Hansen, and to all the members of the Health and Human Services Committee. My name is Senator Carol Blood, spelled C-A-R-O-L. B as in boy, L-O-O-D as in dog, and I represent District 3, which is the western half of Bellevue and southeastern part of Papillion, Nebraska. Thank you for the opportunity to bring forward LB 12, which seeks a process that allows for greater access to human breast milk. Now, I want to be very clear from the start. The purpose of this bill is not to create a breast milk grocery store, not to make breast milk a commodity. The purpose of this bill is to allow DHHS to establish standards for transporting, processing, distributing, and for the safety of human breast milk. They have the ability to do this by forming a committee of subject matter experts to create the aforementioned standards and any needed programming. Now, once a framework is crafted, a broader process will be more readily available in both rural and urban communities to better lift up our at-risk infants under 6 months of age. Now, if you've had an opportunity to look also at LB 13, you'll find a description of whom we hope to help. Now, as I talk later in my introduction as to what other states have to offer, I believe that you'll have a greater understanding of whom we'd like to serve with this idea. If you read a recent story, which I've handed out in our NCSL newsletter that is provided to all senators, you may have noted the story referring to breast milk as liquid gold. That is actually a really good description, and let me share with you why that is. The short-term benefits of exclusive breastfeeding include reduced risks of ear infections and stomach bugs, and the long-term benefits include reduced risk of sudden infant death syndrome, asthma, obesity, and type 1 diabetes. But breast milk can be even more important for our preterm infants who have an increased risk of necrotizing enterocolitis. I've said that, but close enough. A gastrointestinal disorder that causes inflammation of intestinal tissue, which can lead to serious illness and sometimes death. Now, breast milk has a protective effect against the disorder and promotes neurological development. The American Academy of Pediatrics recommends that very low birth weight infants be given donor milk when a mother's milk is unavailable. However, not all preterm and seriously ill infants in neonatal intensive care units have access to donor milk. Not all hospitals prescribe donor milk or have it on site. Hospitals bear the cost of storing, preparing, and supplying the milk, even when the milk itself is covered by insurance. So let's be real. There is clearly scientific consensus that breast milk is an essential medicine for infants at risk or on the cusp of life or death when it comes to preventing infections or brain health. The irony is that the babies who need breast milk the most are also the most likely demographic who have trouble finding it, often because of income or lack of insurance. Mothers who deliver premature infants are often unable to produce enough breast milk. Sometimes that can be a combination of a premature infant's ability to suckle, stress, and separation when a child is in ICU or medical complications. In Nebraska, having a human breast milk bank allows us to not only help those babies, but will be accessible statewide, giving all of our babies in Nebraska a fighting chance. So I'd like to walk you through, how other states utilize their breast milk banks to give you a grasp of what is being done to help infants. We aren't creating a type of grocery store for breast milk shopping. These banks usually have pasteurized, donated human breast milk, which may include human milk fortifiers if indicated by a licensed medical practitioner, and is covered either by Medicaid or insurance providers, depending on the state. Now, as I previously noted, the eligible person is consistently an infant less than 6 months of age. A licensed medical practitioner prescribes the milk for the infant, and the milk is obtained from a human milk bank that meets quality guidelines, usually established by the Human Milk Banking Association of North America, or is licensed by the department in that state. The infant's mother needs to be medically or physically unable to produce maternal breast milk or produce maternal breast milk in sufficient quantities to meet the infant's needs, or the maternal breast milk is insufficient because it has something wrong with it. The milk has been determined to be medically necessary for the infant, and one or more of the following applies. The infant's birth weight needs to be below 1,500 grams, which is almost 3.5 pounds. The infant has a congenital or acquired condition that places the infant at high risk for development of necrotizing enterocolitis. The infant has infant hypoglycemia. The infant has congenital heart disease. The infant has had or will have an organ transplant. The infant has sepsis, or the infant has any other serious congenital or acquired condition for which the use of human breast milk is medically necessary and supports the treatment and recovery of the infant. Now, there are more details I could share about how other states handle this issue, but those guidelines are pretty much the norm for most statewide human milk banks. So the secondary issue is how we consistently hear how we need to do more for Nebraska moms and infants as part of being a pro-life state. So now's the time for us to put our money where our mouth is. Other states have increased access to donor milk by requiring insurance coverage, both public and commercial, because they understand its importance. As of September, at least 17 states and the District of Columbia have enacted legislation requiring Medicaid coverage for donor milk. Indiana became the most recent state last August. Coverage varies based on the patient's length of time and settings. Coverage is required when donor milk is considered medically necessary, but again, state definitions vary. For example, Illinois requires an infant to meet one of 7 medical requirements, ranging from low birth weight to hypoglycemia, and you heard some of those in the previous paragraph. Louisiana considers donor milk medically necessary when several criteria are met, including infant health, caregiver ability, and source of donated milk. State laws also differ in coverage period. Kansas covers up to 3 months of donor milk, New Jersey up to 6 months, and Louisiana up to 12 months. But these laws are not about the mechanics of today's bill. They are just an example of how important this issue has become in healthcare. When we look to other states in reference to human milk banks, we note that in recent sessions, states also increased access to donor milk by creating or regulating milk banks. Legislation for an Arkansas milk bank was brought forward after learning that the state was buying milk from neighboring states. During shortages, milk banks were prioritizing hospitals in their own states. With the high preterm birth rate and the high rate of Medicaid-covered babies, Arkansas was sending thousands of dollars to other states. Now, Arkansas spends Medicaid dollars in the state, and Arkansas mothers have a place to donate their milk. Clearly a step towards reducing the state's infant mortality rate because of the nutritional benefits of breast milk, and a prompt for doctors to prescribe donor human milk. Pennsylvania requires the State Department of Health to license milk banks and mandates that milk banks screen donors and pasteurize and test the milk. The law also creates licensing fees and prohibits the sale of human milk by unlicensed milk banks to ensure that donated milk is safe for infants. States can statutorily regulate milk or change rules and guidelines after legislation passes. For example, Maryland regulates donor milk as a human tissue. And Texas requires that human donor milk banks follow guidelines set by the state health department. Selling breast milk is not illegal, by the way, but clearly unregulated in most instances. So, how DHHS chooses to create Nebraska's human milk bank will depend on the experts that it brings to the table. There are tens of millions of federal funds available right now that are included in the labor, HHS, and agricultural appropriation bills, as well as other grant programming such as ACF grants and grants from healthcare networks that could be used. An existing human milk depot infrastructure could be utilized at a Nebraska hospital, and we wouldn't have to reinvent the wheel. We know there are at least 28 accredited human milk banks in North America and a lot of legislation in play across the country to increase those numbers. Now it's time for Nebraska to do the same. What we decide to do in our own state is left up to the experts, of which we have many in both DHHS and across our state. This is more about the programming and how we can share resources than it is about creating something from scratch. With that, I encourage you to save any questions after today's testimony from our supporters and possibly opposition. Allow them to speak as you may have questions answered during their testimony. I'm always happy to answer questions, but because I respect your time, I do ask that you save your questions for the people testifying, and then I'd be happy to come up at the end and answer any that may still be remaining. Thank you for your time.
Thank you. Are there any questions from the committee? Seeing none. Thank you. I'll see you when you close. All right, with that, we'll take our first testifier in support of LB 12. Good morning.
Good morning. My name is Kathy Leeper, KATHYLEEPER, and I'm a physician and the medical director of MilkWorks, testifying in support of LB 12. Thank you, Senator Blood, for calling attention to the importance of human milk. MilkWorks is a nonprofit community breastfeeding center that has served families throughout the state of Nebraska for 22 years this week. The mission of our organization is to create a healthier community by empowering families to meet their breastfeeding goals. MilkWorks provides individual clinical lactation support in person from board-certified professionals, both in Lincoln and Omaha, and via telehealth to the rest of Nebraska, as well as education in the form of support groups, classes, and via our website. We worked very hard to help babies receive milk made specifically for them by their own mothers, but the lack of cultural support and sometimes medical issues prevent many mothers from being able to fully meet their own baby's needs. MilkWorks is a milk depot for the existing milk bank in Denver, meaning mothers in Nebraska with excess breast milk who have been screened for communicable disease and unsafe medications voluntarily bring frozen milk to us, and we send it to Denver for processing. The Denver Milk Bank is accredited by HUMBANA, which has been mentioned, which stands for the Human Milk Banking Association of North America. Founded in 1985, it has 31 accredited nonprofit milk banks in the US and Canada and set international guidelines for pasteurized donor human milk. The Mother's Milk Bank in Denver sends back bottles of the frozen, pooled, and pasteurized milk at a cost of $4.75 per ounce plus shipping and handling, for an ultimate cost of about $25 for each 4-ounce bottle. We provide a family working with one of our lactation consultants with one bottle of this precious milk for newborns who have lost too much weight while waiting for their mother's own milk production to increase. Because supplementation is often only needed for 1 or 2 days and the volumes needed are small, some families who can afford it choose to purchase a few bottles, but the cost prohibits longer-term use. So most pasteurized donor milk is used in the hospital setting, in the neonatal intensive care unit, as you've heard, where it's been proven to greatly decrease death and illness in premature babies whose mothers cannot provide enough of their own milk. The closest Humana milk banks to us are in Denver and Iowa City, which are over 480 and 300 miles from here, respectively. Having a milk bank in Nebraska would decrease the need to ship the milk so far from our population centers and presumably increase availability to our most vulnerable citizens. MilkWorks recommends that subject matter experts be consulted to finalize the wording and implementation of this bill, and that Humana's guidelines be utilized in creating Nebraska's human milk bank. I would welcome the opportunity to work with you and hope that this is the first step toward providing each one of Nebraska's babies with human milk for the recommended minimum of 2 years, ideally from their own mother, but from other Nebraska mothers when this is not possible.
All right, thank you for your testimony. Are there any questions from the committee? Yes, Senator Riepe.
Thank you, Chairman Hansen. My question is, do we have any idea what the supply and demand within the state would be?
As far as what the hospital demand would be, I do not. I learned of this bill a week ago and I have not had much time to consider that.
Do we have any hospitals in the state of Nebraska that provide this service?
Yes,
And are they spread across the state or are they concentrated in urban areas?
I would assume they're concentrated in urban areas. Not even all the hospitals in urban areas are using it, to my knowledge.
Another question I have, made, Mr. Chairman.
Yep.
Is, I assume there's a screening process to make sure that the product is,
Correct. That's why it's so expensive. Mhm.
okay.
So each mother is screened with blood work and a questionnaire, and then there's random screening of the milk itself before
Is
and
there-
after
Would there be
processing.
an expiration date on the milk then? Like,
That's a really good question. I don't know the answer to that question.
oh, good, I stumped
We-
the man.
We never have it sit around that long. I'm assuming, I mean, it's generally recommended that you not use milk that's been frozen more than a year.
And the question always gets to these too is the refrigeration standard in terms of any product that's mailed. And
Mhm.
I'm curious that in your thing, you talk about Iowa City, which is way off balance from the center of
Yes.
Iowa.
Mhm.
And I can only assume that that's associated with the medical school there.
Mhm.
Is that right?
I would assume so too. I do not know that for a fact. Mhm.
Okay.
Yeah,
Well,
it's
thank you.
shipped frozen.
Thank you for being here today.
Sure.
Thank you, Mr. Chairman.
Mhm.
Any other questions from the committee? I have a couple.
Okay.
So is MilkWorks, is that a private company?
It's a nonprofit entity.
Okay.
Mhm.
So right now, because we don't have this legislation in place, you can't open up here in Nebraska? Or do you need this to open a distribution facility here in Nebraska?
No, I don't understand your question. We're a nonprofit breastfeeding support center that provides clinical support. 5 IBCLCs in Lincoln and in Omaha
Okay.
each. And we have it available for the baby who's lost too much weight. The parents don't want to use formula to use in a 3-day-old to bridge when the mother's milk is coming in.
Okay, I'm just trying to figure out what the business is. So do you collect or does?
We're a
does
milk
DHHS
depot. We're a milk depot. So there are several points in the state where women can bring their frozen milk after the Denver Milk Bank has already screened them.
Gotcha, okay.
And they have a number and we don't even know their name, but they bring in milk number 51403 in baggies that are frozen and we store it in a large deep freeze. And when we get enough, we ship it in big boxes that the milk bank provides us, unprocessed to the milk bank, that then pools the milk all together, pasteurizes it, packs it in little 4-ounce bottles and ships some of it back to us.
Okay, I was trying to figure out
So
the line of,
yes.
okay, that makes sense now.
Yes, so Right. So we're not connected directly with the milk bank. We use a little milk and we work as a depot to collect a lot of milk to send to them,
Okay.
both in Lincoln and Omaha.
And does it require, like, I think Senator Riepe was kind of touching on this, breast milk, does it require special shipping? Since it's
No,
like
it just
human, I don't know.
It just needs to be frozen. It's not a biohazard. The CDC does not consider breast milk a hazardous substance.
Hope not.
Thus, women can store it in their fridge at work and such. So,
Okay,
yeah.
awesome, cool,
Mhm.
thanks.
Oh.
Yes, Senator Hart.
Thanks for being here.
Sure.
Is there payment, financial remuneration for ladies who provide the milk?
No,
Or
it's
is it like
voluntary. Very
donating
good
blood
question.
or-
Yes,
okay.
it's just like that. It's
Very
donated out of the goodness of their heart.
Thanks.
Is it
Senator
tax
Walz.
deductible? Excuse me.
Is purchasing milk tax deductible?
The donation? has to
Oh,
be-
no, no, no. Mm-mm. No.
Okay. Sorry, sir.
Senator Walz.
Thank you. So right now you're working with Denver,
Mhm.
right?
Mhm. Simply
That's kind of what
because
their main,
Simply because they existed before Iowa City, so we
okay.
established a relationship.
Do you know if Milkworks in Denver, does it have to be overseen by the Department of Health and Human Services there in Colorado?
Milkworks in Denver or the milk bank?
Oh, the milk bank, sorry.
I do not know I do not know the answer to that question.
Okay, all right, thank you.
Mhm.
Any other questions? All right, seeing none, thank you. We'll take our next testifier in support.
Good morning,
Welcome.
Chairperson Hansen and members of the committee. My name is Ann Seacrest, ANNSEACREST, and thank you for allowing me to testify on LB 12. I have been a Nebraska resident for over 40 years, and I currently reside at 2309 Lake Street in Lincoln. As a registered nurse and an international board-certified lactation consultant, I have spent over 45 years committed to the well-being of mothers and their babies, with a special focus on lactation as a clinician, advocate, and an administrator. As a past president of the Lincoln Lancaster County Board of Health, my commitment to infant nutrition really began based in public health and our need to improve the health of all citizens in the state of Nebraska. One of the things I'd like to mention, and I think that Senator Blood and Dr. Riepe have done an excellent job of providing lots of information, is that this is not a new concept. The idea of mothers sharing their milk with other mothers has been around since the beginning of time. We used to call them wet nurses. And this also is something that happens around the world with much greater frequency than it happens in our own country. So it's fascinating to look at what is the standard around the world in this area. I also wanted to just mention that Hambana, which is the accrediting organization, does not really it accredits human milk banks. It doesn't really deal with legislation regarding them. It doesn't set legislation regarding them. So I'm testifying today in support of LB 12, but I do have some concerns regarding the process and the wording behind the bill. So we have an infant nutrition crisis in our country and in our state. Only 33% of all Nebraska infants and 10% of low-income infants are exclusively breastfed for the recommended 6 months. So we've made some progress. 15 years ago, only 10% of Nebraska babies were breastfed for 6 months, but we have a long ways to go. Low breastfeeding rates, as you've heard, result in costly healthcare expenditures, unnecessary lifelong suffering. Infants who are fed formula, which is a processed cow's milk, which is devoid of vital hormones, growth factors, and antibodies, are more likely, as you've heard, to die of SIDS and have lifelong chronic and acute health issues. So all mothers do not have the ability to make enough milk for their own babies, nor do we provide them with the necessary support. So banked milk from an accredited milk bank is one solution to increasing access. So while I encourage you to support a Nebraska milk bank, I have the following concerns. LB 12 was apparently drafted without an interim hearing and without subject matter experts involved. Furthermore, the wording of the bill does not require that our health department involve subject matter experts. It says they may. The word commercial in section 1 needs some clarification. Hambana, which is the Milk Bank Association, the accreditation organization, is based on a not-for-profit distribution of human milk. The word commercial could be interpreted to address a for-profit milk bank. No one should make money off the health and well-being of vulnerable mothers and babies in our state. So an accredited milk bank is a really important way to increase access to human milk, but it's really vital that we not ignore other avenues of support nor limit access to human milk in other ways. There are other states that are doing some innovative programs that are providing lower cost milk share programs that allow milk to be available for babies that are not vulnerable babies. So I really want to thank Senator Blood for bringing LB 12 forward. This bill needs expert input, and we need to make sure that it preserves the intent of milk banks. We all know that once legislation is enacted, it's really hard to reverse it. So we want a bill that's worded with the best intent and the best language. Thank you for your time and consideration.
Thank you for your testimony. Are there any questions from the committee? Yes, Senator Kavanaugh.
Thank you. Thank you so much for your testimony. This is an issue near and dear to my heart. I have, of course, utilized MilkWorks services, so thank you for that, and utilized milk from the hospital as well. And my question is, and I apologize if you're not the right person to ask, but so our hospitals some of them have access to human milk.
Yeah.
Do you know what the process is for that? How do they have access? Do they send it to Denver, or do they purchase it from Denver?
So the hospitals would be purchasing it from an accredited milk bank.
Okay.
I know that the 2 hospitals in Lincoln have access to it. I'm not sure how many in Omaha do. And I'm not sure if any of the smaller hospitals across the state are accessing bank milk. They typically use it under certain circumstances.
Mm-hmm. There's a form that you fill out and you check if you're willing to accept
Yes.
human milk when you're in the hospital with a newborn, which I've checked 3 times. It's just I appreciate the education from all of our introducer and our testifiers this morning, because listening to some of the questions, it does occur to me that perhaps this is an under-discussed issue.
Correct. And that's why I think that sometimes if you mention this topic to people, they go, what? Where on earth did that come from? And what are we even thinking about that? I mean, it's not so long ago in our state that if you mentioned donor milk to someone, it was like, oh no, am I going to get poisoned from it? Whatever. So this is something that should be, and it may be very, very new to all of you, but keep in mind, this is not something that's just started to happen. It's been happening since the beginning of time.
Well, I appreciate your testimony, and I think you buried the lead that you founded MilkWorks, but I know you're no longer with them, but appreciate your service and what you've done for mothers in Nebraska.
Okay. Thank you. And thanks to all of you.
Yeah, one second.
Yes.
Yeah. Are there any other questions? Yes, Senator Riepe.
I'm inclined, I have to look at the numbers as well. And my assumption is if it's, as it's stated in a previous testifier from MilkWorks, was that it would be $25 for each 4-ounce bottle.
Yes.
So I'm saying, okay, if it's $25 times 7 days a week, that's $175 per week.
No,
Times 6 months, let me finish, please. 6 months, which means $4,200.
it's going to be more than that. Because what happens is when bank milk is used right now, particularly in a clinical setting like MilkWorks, it's used with a newborn baby that doesn't need that much milk. They might need a couple ounces in that first week a day, so they might need $5 worth of milk a day as mom's milk supply is coming in. But a baby that's going to work their way up to about 30 ounces a day, so babies take about 20 to 30 ounces a day on average of milk in their first 6 months of life. So you're looking at up to 30 ounces a day at that price. So I had a conversation a number of years ago at a gathering in Washington, D.C., where they brought together nonprofits and kind of grassroots organizations from around the country. And I had a conversation with someone from the milk bank, and I really said, what can we do to bring the cost down? And she really said it's about volume. We really have to, it's a volume-driven cost factor, and we really need to get the volume going. And once we get the volume going, that will bring that cost down. But it's also, when you add in the transportation, you add in a lot of issues like that, it just really does increase the cost. So the closer we can bring banked milk to the mom and to the donor mom and the recipient mom, we are going to bring that cost down. But yeah, you're talking a higher cost than what you're mentioning, Senator. That's why it's not available. That's why it's so strictly restricted.
You want one more? Yep, go for it.
Please. Thank you, Chairman. I guess my question gets to be is if commercial doesn't recognize it and Medicaid does recognize it, we've also set a richer benefit for Medicaid than what commercial buyers are able to get on their private healthcare insurance. And so we spread that margin and make being on Medicaid more attractive than having private insurance. That's a concern. I know that's hard and cold, but it's the numbers.
No, I think somewhat a little bit here we're venturing into unknown territory. I mean, insurance reimbursement for lactation support was unheard of even not that long ago. So now we're talking about insurance reimbursement for human milk. So I can't answer that. It's something I've not thought of before as we venture into this. I think what we do know is we need a better food product available for babies. We need a human milk product available for all babies, particularly vulnerable babies. And how are we going to go about doing that? There's lots of ways to do that, like supporting moms in the workforce, having paid maternity leave so they can be home with their babies. So there's lots of ways we can do it. This is one avenue to try and provide it for the most vulnerable babies who cost all of us a lot of money when they end up with NEC. Which I have difficulty pronouncing also, okay? So I call it by its shortened version. So all of those conditions where babies end up very sick in NICUs because of their prematurity and their other issues, they cost all of us a lot of money. I'd rather be spending that money on getting them human milk to prevent NEC. And I'm a taxpayer.
Yes, Senator Walz.
Thank you. I'm just curious, what is preventing us from creating a milk bank here in Nebraska right now?
Well, I would say, and I would turn that over to Senator Blood and what you found out, but I mean, I would say that, what happens is generally in each state, there's an institution. It's usually a hospital, a medical center, a medical school, something like that, that believes in this concept and gets behind it. Generally, milk banks are not, well, they're not for profit. If they're connected with HMBANA, which is the Human Milk Bank Association of North America, they're not for profit. So they're a charitable organization that believes in this mission of improved health and well-being for babies and mothers.
Okay. So nothing really is stopping us from just
Not that I'm aware of.
right place to put it. Okay, thank you.
Can I ask some questions too?
Sure.
So right now, is it legal in the state of Nebraska, just because I'm unfamiliar, for you to just buy breast milk from somebody else, like your neighbor?
It is not regulated. It's not regulated by the FDA. There is federal legislation on making federal standards for all states right now for the country, but that has not passed yet. Senator Duckworth has been involved with that. So yes, what's really scary right now is that some moms will get milk off the internet from moms they do not know and do not really actually know it's milk. One of the best alternatives to a formal milk bank is a program in Wisconsin, where what they do is they do an informal milk share in the community where they screen moms, like we talked about, with blood tests. The major issue with milk share is transferring the milk, making sure it's milk and transferring the milk in a clean manner. There's not a lot that will transfer from one mom's milk to another milk. HIV is probably the one we're most worried about. So no, most moms will donate milk to other moms in the state right now. But are there some moms that are probably selling their milk? Probably. I mean, I don't know. I can't tell you personally anyone, but yes, I would guess that it's happening.
Okay, good, because that's what we did for our daughter. I want to make sure I say that before it's legal. My daughter was born at 4 pounds, and so I had my wife, there's some issues there, and so we ended up from people we knew, personally.
Yep.
So,
Yep.
and bringing home coolerfuls of milk, breast milk, and then I made it myself, and so it just worked out really well. And so it's
And you could home pasteurize it if you want to. So you could take mom from another mom and pasteurize it, which is just a heat treatment that would then get rid of anything that possibly got into it during the transfer. But think of this, if you were a mom who your doctor, your midwife, the hospitals, everybody told you, you need to breastfeed your baby. It is the best thing for your baby. And then for some circumstance, you don't have the milk. What are you going to feel like? You're going to feel further stressed. You're going to feel like a failure. You're going to feel like you're not doing your baby right. So you're going to get that milk wherever you can.
so we did. I didn't care. Okay. Any other questions? All right.
Thank you so much.
Take our next testifier in support. All right.
Good morning.
Morning.
Thank you, Chair Hansen. Good morning, members of the committee. I am Lacey Bolte, LACIE BOLTE, and I work for Nebraska AIDS Project. We are a nonprofit organization serving individuals with HIV across the state. And I don't really want to take up a whole lot of your time, but just wanted to note that parents who are living with HIV, we have wonderful, wonderful medical resources where babies can be born HIV negative, but mothers cannot breastfeed. And so having access to a milk bank would keep those babies healthy and those mothers protected. That's all I have. If there's any questions, I'd be happy to answer.
Are there any questions from the committee? Seeing none, thank you for
Thank
coming
you.
up. Appreciate it. Anybody else testifying in support? Okay. Is there anybody who wishes to testify in opposition to LB 12? Is there anybody who wishes to testify in a neutral capacity? Welcome.
Good morning. Good morning, Senator Hansen and members of the Health and Human Services Committee. I am Dr. Ann Anderson Berry, for the record, ANNANDERSON BERRY. I am a UNMC faculty member and the medical director for the Nebraska Perinatal Quality Improvement Collaborative, NPIC. However, today I am not speaking as a representative of the university. I'm here today to testify on behalf of NPIC and in my role as a private citizen with professional expertise on the value of breast milk for babies. I'm a neonatologist by practice, so I take care of these infants that have been referred to in the previous testimony in the neonatal ICU. Our group covers most of the state volume for these critically ill infants. And I also have a PhD in medical nutrition, specifically around breast milk and feeding the sick preterm infant. I understand that there are ongoing conversations on how to enhance donor milk availability specifically to rural areas, and I'd like to thank Senator Blood for introducing this bill. As a medical director of MPIC, I coordinate collaboration with all of Nebraska's delivery hospitals, support perinatal clinicians, and serve Nebraska communities. With other public health leaders and key stakeholders, we are committed to improving healthcare and outcomes for all Nebraska mothers and babies. Implementation of quality improvement initiatives to address perinatal health issues and reduce maternal and infant morbidity and mortality is a key part of this work. In fact, one of our first collaborative initiatives was to increase exclusive breastfeeding in the first days of life across our Nebraska birthing hospitals, and we've made great improvements in this for Nebraska. Breast milk is the best source of nutrition for newborns, especially for those who are ill or premature. It provides all the necessary nutrients for growth and development and contains antibodies and other immune-boosting factors that can protect against infection. According to a study published in the Journal of Pediatrics, premature infants who were fed breast milk had a lower risk of death and chronic lung disease compared to those that were fed formula. Donor milk is a product that is collected from mothers who have surplus supply after providing for their own infant's nutrition. It is typically collected in a plastic container, frozen, transported to a processing milk bank where it is thawed, put in an additional container, tested for substances and infectious agents such as viruses and bacteria, frozen, thawed, heat pasteurized, retested for bacterial contamination, placed into plastic containers, refrozen, and then stored for weeks to months prior to shipping to hospitals where the milk is then stored frozen until it is needed for an ill infant. At this point, it is thawed and put into another plastic container to be delivered to the patient. This handling is important to understand as it degrades the nutrients present in the breast milk significantly. Plastic containers bind nutrients, antibodies, and proteins are denatured, and fat-soluble vitamins, including A, E, and the carotenoids, are present at levels of only 18 to 53% of mother's own milk. Donor milk is frequently used as a bridge to mother's own milk in the hospital intensive care setting, but is not an ideal form of sole nutrition for a neonate. To best benefit moms in Nebraska and their babies, we need to ensure that we have appropriate lactation support, high-quality breast pumps for women with state insurance, time at work to pump, and safe places in every workplace to express breast milk. Thank you, Senator Blood, for your steadfast advocacy for perinatal health. Support for breastfeeding in Nebraska is critically important as mothers strive to provide breast milk for their infants. LB 12 provides an opportunity for us to discuss how to enhance the availability of donor milk in rural areas. Healthcare professionals like myself and the NPIC would be pleased to work with DHHS to see how access to donor milk and breastfeeding rates could be improved here in Nebraska. Currently, all hospitalized NICU patients have access to donor milk or shelf-stable commercialized donated milk. So it is not an issue of access across the state for neonates in intensive care units. What happens in some of the smaller rural communities for those infants that aren't in an ICU but may need a bridge to breast milk is the hospitals can't afford to buy it for those families. And so that's where LB 13 really is going to make a big impact. I'm not sure that LB 12 in its current language is ready to move. I would agree with the other testifiers that it needs some significant language modifications. And really the biggest bang for the Nebraska taxpayers' dollar is to support lactation, get more lactation specialists in the communities across the states, get more pumping availability, support the moms so that they can provide their own breast milk, which is nutritionally so much more important than donor milk. Thank you, and I'd be happy to answer any questions.
Thank you. Are there any questions? I think you answered my question. I was just about to ask, like, what the nutritional value of breast milk is after you pasteurize it. I would assume it'd break it down or,
Yeah, it
alter it in some
denatures
way.
the protein, it denatures the antibodies, it destroys many of the fat-soluble micronutrients. The ones that I've listed and are in the graph on your sheet from my testimony are the fat-soluble micronutrients that grow babies' brains and vision, particularly the carotenoids, luteins, zeaxanthin, vitamin A. If we're feeding infants 18 to 50% of the intended concentrations of those, and we're proposing to do that for a 6-month period, we're going to have infants that are malnourished in our own state. Formula is nowhere near as good as mother's own milk, but in many cases, it is better than donor milk for the long term. We use donor milk as a bridge to mother's own milk and to protect our smallest, sickest infants from the things that you've heard about, necrotizing enterocolitis or neck, chronic lung disease, retinopathy of prematurity. Donor milk has a place, but it has a limited place, and our babies in Nebraska are getting that now. We have milk depots that send milk not only to the Colorado Milk Bank, but the Iowa Milk Bank. We have, all of our hospitals have the ability to purchase milk from those banks, from Milk Bank of Austin, from commercial companies that provide a shelf-stable breast milk doesn't require freezing, that's a great solution for our smaller rural hospitals because they can invest in that and know that they're not going to have to throw it away after a couple of months when it expires. So there are a lot of solutions in play right now for our hospitalized infants. The cost is prohibitive for some of our smaller hospital systems, but I know because I work with them directly that all of our NICUs, our level 2 NICUs in Kearney, Grand Island, North Platte, Hastings, Norfolk, they're using donor milk. All of the units in Omaha and Lincoln are using donor milk. It's those critical access hospitals who might take care of a moderately ill infant that could benefit from a supplement of donor milk that really aren't getting that in right now because of cost. And so there is a role for it. I think LB 13, which I'll be back to testify for next week, would solve a lot of those issues. It's expensive, to Senator Riepe's point. So, we have to decide how are we going to invest. I would love to see more lactation support.
Do they have to pasteurize it? Like if you're testing it already for viruses and bacteria beforehand, wouldn't that be adequate, or is it more just kind of a?
It needs to be pasteurized or else it will go bad more quickly. And I think that no hospital from a medical legal risk standpoint would administer a donor product that wasn't pasteurized. Yeah, it's a complicated.
I'm sure you probably use it within a week or two.
We try to keep a par and rotate our stock so that ours does not go bad. We don't use the shelf stable in the institutions that I practice in. Other institutions use the shelf stable, and so they can order a year's supply and it'll be just fine. So it just depends on your practice, and the costs are pretty equivalent. The other thing that is concerning to me is, milk banks are incredibly expensive to open and to run. San Diego just opened a milk bank. The opening costs were $5 million. And then you've got to run it, and you have to have someone who understands human milk food processing, who can perform all these tests. And as one of the previous testifiers mentioned, it's a volume issue, and we're a state of 2 million people. We have 25,000 deliveries at best each year. We've drifted as low as 20,000 deliveries. We don't have, in my professional opinion, the volume to support our own milk bank.
Okay, all right. I just ruined my dream of opening a milk bank.
It would be expensive. If you are independently rich, Senator Hansen, I would support you in that.
I'm a Nebraska state senator. That's not going to happen.
Well noted.
Thank you for testifying. I appreciate it.
Thank you.
All right. Is there anybody else wishing to testify in neutral capacity? All right. Seeing none, welcome Senator Blood back up to close. And just the record, if I could real quick, there were some letters, 12 letters of support for LB 12 and 3 against, for the record.
So let's unpack some of what's been said today. So I agree the language is wonky. I don't know if you've noticed that that's been quite a few bills this year. We've got a lot of new bill drafters, no offense to bill drafting, but I understood what the intent was behind words like commercial. They know that if there's a cost involved, that they thought the word commercial needed to be included in that. I don't agree with that. I agree commercial doesn't belong in this bill. And I have no issue with changing the language. In reference to not having an interim hearing, for those of us that have followed the legislature for decades, you remember that prior to 2014, and unless I go and I research the dates, I can't tell you the exact dates, but Nebraska was doing a really bad job of making sure that mothers were getting the help they needed for breastfeeding. We weren't in the front of the pack, we were in the back of the pack. And so some bills were passed, some initiatives were moved forward, DHHS got involved, and now we've moved forward when it comes to that initiative. But statistically, we don't need more interim hearings, we don't need more data. We know the importance of breast milk in Nebraska. We know that we were previously at the back of the pack here in Nebraska, and we want to stay in the front of the pack. What else is wrong with this language, and why I was so specific in my introduction, is that we're going to get the subject matter experts together to decide. And again, we may have to amend the bill as it's written, but the intent The intent is to get these experts together, decide can we, how can we, and take advantage, and if we can, and take advantage of the federal funds that are available right now. We have a window of opportunity to fund something fantastic. But, you know, Colorado, Iowa, I mean, state after state, read that article, by the way, that I gave to you, they continue to be leaders. And although we may have the milk available for our infants in NICU, you saw what happened when we had the shortage when it came to formula. What were people doing? They were going online and they were buying breast milk. Like, I don't think we've expressed today the importance of breast milk, and not every mom has that benefit when their child is sick. My daughter, who will be 40 this year, my oldest, was 3.5 pounds when she was born. She was 2 months premature. And I was one of the lucky moms that I was able to still provide breast milk for my daughter. But that wasn't always the norm. And I remember seeing other moms crying and upset because they felt less than, which of course it doesn't make you less than, it just means you got to find an alternative, right? I just feel like we can do better in Nebraska. I don't disagree with anything that's been said. I don't think the neutral is definitely neutral. I thought it was more in opposition, and that's okay. But we aren't ignoring the experts. I see the data that we've been given in Nebraska over and over and over again. It shows that we need to keep working forward when it comes to providing access to breast milk and educating people on breast milk. And the intent of the bill really was to put subject matter experts together to see if we can do better. And to be really frank, I think the language is a bit misleading in LB 12. It's wonky language, but we never really could get it to where we needed it. LB 13 is not wonky. I'll warn you in advance, that one's a good one. So, but I also, it's verbatim basically what I put in my bill request. So I do hope you consider this. We can work on an amendment. I don't see the issue with putting a bunch of subject matter experts together who say that they want to be involved to see how we can move forward with DHHS and make it more accessible, make it easier. And she's right, to build a breast bank, we're talking about millions of dollars. But again, there are millions of dollars available. And so are there resources that we can utilize within our state to maybe create something, not necessarily a breast bank, but a way that we can make it more readily available to those most in need? Because not every child in need is in NICU, as we all know, if we've had premature infants. So with that, I hope that you will work with me on this one. I look forward to talking about LB 13 with you in the future as well. And Senator Riepe, I want to say that when we help our children that are most in need, we actually save Medicaid money, like considerable money. These infants that are prescribed, it isn't that, again, we're not talking about a breast milk grocery store. These children are prescribed by doctors that they need this breast milk. And the fact that we're more willing to give a child medication over breast milk, I think is kind of crazy. And ultimately would probably even cost the state more. So I don't know. I think that nature has provided probably the best medicine that every child needs, and that's a mother's milk. I'm always surprised that there's still a weird stigma attached when we would talk about it in rooms full of adults. You may have remembered one of my very first bills was that in Nebraska, you could still be cited for breastfeeding in public, which is crazy, right? We just have to keep moving forward. We have to do better for our moms. It wasn't that long ago that we were not doing well on the report card on breastfeeding for Nebraska. It was actually quite embarrassing. I know, I could talk all day about breastfeeding. So with that, I appreciate all the questions. I don't disagree that the language is wonky. I disagree about the interim study because we already had the data, and we've had the data for a very long time, and it's continually updated. We have subject matter experts willing to meet with DHHS. DHHS is willing to meet with them, so they're not here saying this is horrible. We've met with them. I think this is something that we could amend and do something with.
Okay, thank you. Are there any questions from the committee? Seeing none.
All right, thank you
There
for
you
your time. I know you guys are going to have a long day today.
Uh-huh.
And God bless you all for doing it.
All right,
I'm glad I'm on
thank
this
you.
committee.
All right, and I'll close the hearing on LB 12. We'll now open the hearing for LB 181, which is my bill, and I'll be up there in 2 seconds to open.
Welcome, Senator Hansen.
Morning, Vice Chair Harden and members of the HHS Committee. My name is Ben Hansen, that's BenHansen. I am opening today on LB 181, a bill that would authorize pharmacists to fill prescriptions in specific situations. You will see I have included an amendment to exclude veterinarians from this legislation. They have their own set of standards to follow when it comes to prescription, and this satisfies the concerns of all interested parties. But currently, there are uncertainties on how a pharmacist is to proceed when the prescriber of a prescription is no longer practicing. Patients still rely on medications that have either been authorized for refills, are part of a continued subscription, or are qualified for a 90-day one-time emergency refill. Are pharmacists free to dispense medication in these situations? Some assume that prescriptions can still be filled, while others consider the lack of a valid prescriber and patient relationship the reason to halt remaining refills and cancel prescriptions. Federal law is where we get the regulations for prescribers' authorization, but it is vague when talking about emergency refills. LB 181 provides clarity on the issue and allows for continuation of care for patients. They have been diagnosed and have prescriptions that were legally written. Life brings unexpected changes, though, and when a practitioner can no longer serve in such capacity, it is important to have a plan in place and how to respond. LB 181 trusts pharmacists in using the professional judgment to fill emergency refills until the expiration date or until therapy refills to maintain chronic medication. This prescription adaptation ensures patients can care until a new physician is able to provide an authorized prescription. It is my intent as a member of the HHS committee to look for ways to eliminate overburdensome regulations on healthcare workers, cut red tape, and foster an environment that helps providers in doing the jobs they love. I also put an emphasis on the patient and listening to their needs. In the case of LB 181, a situation that prompts the necessity for emergency refills would respect the patient's health care in an effort to offer as much consistency as possible. It would rely on pharmacists' discretion backed by their experience, education, and professional judgment while recognizing the expertise of providers in the authorization process of prescribing subscriptions when emergencies are absent. I would appreciate your support of LB 181 and thank you for your time and consideration this morning. There are testifiers following who can give further insight as to why this is necessary, but I am willing to answer any questions you may have to the best of my ability. Thank you.
Questions, committee? Senator Kavanaugh.
Thank you. Thank you, Senator Hansen.
Mhm.
My question is about your amendment.
Yes.
Why? Why veterinarians?
From my understanding, I think, I don't know how many years ago, 3, 4, 5 years ago, they passed something very similar to this specific for veterinarians. So they're already allowed to do this in just a different capacity that has to do
So
with
this
animals.
is just ensuring that that isn't changed.
Yeah, we're just leaving them out so we don't
Okay.
mess with their stuff.
Thank you.
Any other questions? If not, will you be here to close?
I will be.
Wonderful. Are there any in the proponent category who would like to support LB 181? Don't be shy.
Good morning.
Good morning. Thanks for joining us.
This room has me off my axis. Is anybody left-handed? I feel left-handed now, and I'm not. Good morning.
Thank you.
Senator Hansen, thank you for introducing this bill. My name is Marcia Muting, MarciaMueting. I'm a pharmacist and the CEO of the Nebraska Pharmacists Association. The intent of LB 181 is to allow a pharmacist to fill a prescription issued or refills on a prescription if a prescriber is no longer in practice. As you may recall, this is like a bill passed recently regarding veterinary prescriptions. The idea for this bill came from a group of interested pharmacy students from the University of Nebraska Medical Center College of Pharmacy. They have assisted the NPA in developing this language, and 2 of them are here to testify, and a whole group of young pharmacists, future pharmacists, are here to observe. The language for this bill was modeled after the state of Virginia's law. Texas and North Carolina have policies to specifically address the situation of how to handle prescriptions from deceased prescribers. So here's the scenario. A prescription is written today for a maintenance medication, such as insulin with refills for a year. The prescriber is no longer in practice come April of this year. When the patient returns for a refill to Marcia's Perfect Pharmacy, should the pharmacist be allowed to utilize the previously authorized refills to prevent interruption in therapy? This bill does not allow a pharmacist to add refills to a prescription that has no refills remaining. Prescribers can, right now today, prescribers can write multiple prescriptions for a controlled substance with notes that say do not fill until a specified date. That's legal right now today. They can write 3 prescriptions dated today with instructions on when to fill the remaining prescriptions at a future date. This is a very common practice, especially for prescribing medications for ADHD. So the pharmacy has those prescriptions on file. So should the pharmacist turn away a patient who has valid prescriptions and refills because the prescriber is so suddenly no longer in practice? There are practitioners across the state who don't accept new patients, new Medicaid patients, or new Medicare patients, or they're booking appointments months for routine care months in advance. If the patient can't access a supply of medication until a new prescriber is found, or an appointment can be booked, the only option for the patient and the pharmacist is to go to the emergency room. And emergency care, we know it's costly and should be reserved for patients who are emergent. We've had multiple conversations with individuals who have expressed concerns about this bill, particularly regarding the provisions for providing a 90-day refill. Again, there are issues with finding a clinic who accepts new patients and how far in advance that routine office visit must be booked. I am committed to finding middle ground with the opponents of this bill. Currently, Nebraska law is silent on the validity of a prescription and the remaining refills once a prescriber is no longer in practice. I've been told that pharmacists are already filling prescriptions written by deceased prescribers. However, without enabling language, I'm concerned that pharmacist license will be sanctioned. If a medication is covered by the patient, their insurance, that there's a likelihood that that pharmacy's reimbursement could be clawed back saying prescriber was deceased. I do want to bring to your attention the article that I submitted with my testimony. Table 1 shows that 43 states have some provision for emergency continuation of therapy refills for non-scheduled medications. Only 7 states, including Nebraska, are either silent on emergency continuation of therapy refill provisions or do not allow it. Table 5 reflects another 36 states which have provisions regarding emergency continuation of therapy refills of scheduled medications. Nebraska is conspicuously absent from both tables since it has no provisions in the law to clarify a pharmacist's ability to dispense emergency or continuation of therapy refills. Thank you for the opportunity to testify in support of LB 181. I'm grateful for the opportunity for pharmacy students to actively practice and participate in the legislative process. I ask the committee to advance LB 181, and I would be happy to answer any questions.
Questions, committee? Seeing none, thank you.
Thank you.
Anyone else in support of 181? Welcome.
Good morning. Members of the Health and Human Services Committee, my name is Lydia Fritchie, LYDIA-FRITSCHE. I am representing the American Pharmacist Association Academy of Student Pharmacists chapter at the University of Nebraska Medical Center in supporting LB 181. On behalf of myself and our chapter, I would like to thank Senator Hansen for introducing this bill. I and the other pharmacy students here today are all licensed pharmacist interns in the state of Nebraska and currently working in pharmacies. This bill matters to us because when patients need refills on a medication, they reach out to their pharmacies and they talk to us. If their provider is unavailable for whatever reason, that delays when the patient can receive care and can lead to a lack of adequate control over a chronic condition. Depending on the medication, missing doses can become a serious health concern when a patient forgets they were out of refills and their provider's office is closed for just a couple of days. When a patient is unexpectedly unable to continue their therapy under their usual provider, it can take much longer than that to find a new provider. Currently, they have 3 options if that happens. They can take the time to find a new provider immediately. In the best case scenario, they get transferred to another provider in the same office. And in the worst case, they get put on a waiting list, which can be months long. They could try emergency care. That is usually a last resort because it's expensive and not something we encourage because it takes time and resources from other patients in need of care. Then the last option would be to go without their medications while they find time to look for a new provider, which may not be the healthiest option. When looking at LB 181, we as pharmacy students are looking from a patient care standpoint, specifically for Nebraskan patients. Some patients have enough flexibility and access to health services to find a new provider quickly. That is not the case for all of our patients. Some of the patients we see don't have reliable transportation to go to an appointment immediately. Some have no access to the internet to find a new provider. Others may work long shifts and have trouble finding a provider who fits into their schedule. It's also very possible, considering which state we're in, that the patient is a farmer or a rancher with limited access to healthcare to begin with, and unable to spend the amount of daylight hours it would take to go to a town that has a provider and reestablish a point of care. The patient is not at fault when their provider is suddenly unavailable, but they do have to bear the consequences. Pharmacists go to school to learn about the medications prescribed. They can understand the diagnosis, can see the patient's refill history, and the pharmacy is at least accessible enough that the patient can receive prescriptions from them regularly. This bill makes sense for Nebraska and makes sense to us. It would give patients a 4th option when they have no control over losing their provider to continue treating their chronic conditions while searching for a new provider. We have immense gratitude that our professors, state association, and policymakers have heard our concerns and made this bill a reality. We would continue to ask for this committee's consideration as it decides whether to move this bill to general file for further discussion. I'd be happy to answer any questions you have to the best of my ability.
Thank you. Committee, any questions? I have one.
Yes.
What can you do to steal the gunpowder from the opponents? What would be the problem with this?
I've heard a day supply may be a problem. And that comes back to where we are. Just because I am actually from a rural area myself. So I've seen how hard it can be for a person working on a farm or a ranch to actually be able to get to town. I mean, harvest season comes around and farmers will neglect their health if that becomes a problem. My issue isn't with forgetting, but when their prescriptions become canceled because the prescriber has passed away, retired. Often they don't know about that until they come to the pharmacy, and then what do they do? So as far as day supplies is concerned, I do believe it is reasonable that we have a 3-month limit, but that is obviously up for consideration.
Very good. Well, thank you. Any other questions? Thank you. Anyone else who is a proponent for LB 181?
All right, good morning. My name is Madeline Stubenik, MADALYNNE STUBBENDICK. Yes, I know it's a mouthful, but good morning. I am a third-year student at the University of Nebraska Medical Center's College of Pharmacy. Although today I am speaking as a private citizen and as a member of a rural community. I support the adoption of LB 181 as I think it will have a positive impact on communities across our state. I can attest through my professional experience so far as a pharmacist intern up in Omaha that losing your provider is a difficult situation for patients. In the last several years where I've been working, there have been quite a few practitioners in my area that have retired or passed suddenly. A few of the patients have come to the pharmacy, and the only reason they have knowledge of this is that we tell them that their provider has passed, and that's the issue with not getting a refill on their medication. Thankfully for my patient population, most of the providers up in Omaha have a partner or somebody that they work with in their office, which makes it considerably easier to get new authorizations on prescriptions, although it's not as lucky out in rural communities like where I am originally from. Forwarding that on does sound easy, but I do have to be on the lookout for the potentially a 3-month period for any prescriptions that come in from that provider. Anything I don't catch and forward on to another provider results in a delay of care. There have been many times when I've been in this situation where I have to wonder what more can be done to help our patients. To me, it's frustrating because often I do have a refill on that prescription sitting here forever in kind of a limbo state with the provider no longer being a valid prescriber. This notion is troubling to me because there is, or there was, a valid patient-provider relationship at the time of prescribing. In the course of us filling a prescription for the first time, we clarify any discrepancies, any problems with the prescriber. So typically the only time in the remaining life of the prescription that we usually have any communication from said provider is when they make a professional judgment and decide that an update to a prescription is necessary. For most of my prescriptions, we get it, we fill it, it goes through. I'd like to run you all through a hypothetical situation, and this would be for a member of a rural community. Let's say you have 2 weeks worth of medication left when your longtime doctor has a heart attack and passes away suddenly. You are able, fortunately, to spend a whole afternoon finding a new doctor who is only a county over, but is unwilling to prescribe you any medications until your appointment, your initial appointment, 6 weeks from now. There is no emergency department within an hour of your house, and your pharmacy is unable to fill your prescription because their provider number was deactivated. Under the current system, the only thing you can do in that situation is go a whole month without those medications, so that when you do get to your new appointment, you're not assessing your current health. You're basically starting from square one. Your provider can't determine how your current therapy is working because at this time you have none. Under this bill, a pharmacist could provide you with enough medications to get to that appointment. The pharmacy is temporarily bridging the gap from your last provider to your new provider. This would allow them to have an accurate picture of your current state of health. From there, that doctor can use their clinical judgment to make or not make any changes that they deem necessary. To me, this bill represents an opportunity for pharmacists to help ease the transition of care from one provider to another. It also allows for reduced deaths on the account of the patient who is faced with the daunting task of finding a new provider after their old one is no longer available. As healthcare providers, we strive to facilitate our patients' good health, and I think that LB 181 would achieve just that. I encourage this committee to consider advancing this bill towards general file. I'm happy to answer any questions that anyone may have, and I thank you for your time.
Questions, committee? Seeing none, thank you so much. Anyone else in support of LB 181?
Vice Chair Harden, members of the committee, my name is Robert J. Hallstrom, Hallstrom. I appear before you today on behalf of the Nebraska Pharmacists Association in support of LB 181. I would not typically get up to testify after Marcia Muting has testified on, behalf of the NPA, but Senator Harden, your question spurred my ability to come up here and try to address your question about why the need for the bill based on the gunpowder of the opponents. And I think I'd just note for the record that we have had extensive discussions starting back in October with the Nebraska Medical Association. Appreciated the actions of Amy Reynolds and Paul Henderson in working with us. They had initially expressed some concerns over the provisions of the bill relating to suspension or revocation of the credential, the 90-day supply for an emergency refill, and obviously caveated that by the fact that they had to visit with their members. I think since they've had some visitations with their members, and you'll hear from their testimony later, they may have other issues or concerns with the bill, and that's all fine and well. As Marcia Muting indicated, we're open to amendments to address any legitimate concerns with the scope or breadth of the bill. But basically, I think the suggestions have been that pharmacists are already able to do this, and why do we need a law? The fact of the matter is Nebraska law is silent on this issue. Marcia Muting referred to the tables attached to her testimony that indicated that 43 states have decided to proactively and affirmatively put into law or regulation what the rules of the road are. They have indicated in a few cases that pharmacists are not able to dispense under these circumstances, but in the vast majority of cases, 43 states for non-controlled medications, 36 states for controlled medications, that they do have specific provisions, and they do differ in the length for emergency supplies and so forth. But some rules of the law will provide greater certainty or clarity in this area. And from the research that we did in putting the law together, the basic fundamental question was, what can a pharmacist do after the physician-client-patient relationship is terminated or severed because of death or one of these other conditions addressed in LB 181? And again, other states have chosen to be proactive. I assume the legislature could choose to do nothing and leave the issue unresolved, or in our opinion, the better course of action would be to take action as proposed under LB 181 and remove any uncertainty and provide that clarity that pharmacists and practitioners need. With that, I'd be happy to address any questions.
Thank you, Mr. Hallstrom. Questions from the committee? Seeing none,
Thank you, Senator.
Anyone else in support of LB 181? Seeing none of those, or do we have one more? Well, come on down.
My name is Mark Fritchie, and I'm from Southwest Nebraska, MARKFRITSCHE. I'd like to address the rural proponent of this. As a farmer and rancher, where I live, it's 50 miles to the nearest pharmacy round trip. And the second closest is a 100-mile round trip. So as you can see, a lot of when we renew prescriptions, it's usually on a parts run. So try to make the most of it. As far as putting in long hours, I mean, there are certain seasons when we do that. And, like calving season, I can be fertilizing, spraying, planting, calving, feeding cows, moving pairs. As you can probably guess, it gets to be some pretty long days. And so with that, it is easy to miss your expiration date on your medication. And I guess it would be nice if we could go into a pharmacy with an expired prescription and walk out with that prescription under the circumstances of being, so busy and there's no doubt about it. I have a great deal of respect for the Pharmacy Association. It's a profession that it is their job to know drugs, to know the reaction, to know drug interaction. So I think we're in very capable hands in allowing this to happen. Any questions?
Committee, any thoughts? Senator Riepe.
I'd only like to say thank you for coming in. Obviously, you took an extra effort to do that, and not only that, but all the other testifiers as well. But thank you.
Well, I appreciate that. Did it?
I echo that.
All right.
Anyone
Thank
else?
you very much.
Thank you. Any other supporters of LB 181? Seeing none, any in opposition to LB 181? Welcome.
Thank you. Good morning, Vice Chair Hardin and members of the Health and Human Services Committee. My name is Daniel Rosenquist, DANIEL-ROSENQUIST. I'm a family medicine physician in Columbus and the current president of the Nebraska Medical Association. I'm also here testifying, in opposition to 181 on behalf of the Nebraska Medical Association, but also on behalf of the Nebraska Dental Association at their request. The NMA and the NDA appreciate the goal of this legislation, which we understand is to prevent disruption to patients receiving their prescription medications. We share that goal and value our pharmacy partners. However, we remain opposed to LB 181. Our concern is twofold. First, the bill creates confusion regarding what we expect of pharmacists. In our conversations with the Board of Medicine and Surgery, there was a general puzzlement regarding the rationale behind this legislation. Prescriptions that are valid when written remain valid until filled or expired. No regulatory board or agency expecting pharmacies to check the status of a prescriber's license, their location, or whether they are still living when they receive that valid prescription. These prescriptions are being filled. One of our members shared that in his 2 decades working in a busy emergency department, they have simply not seen this as an issue. Second, I would point you to the letter of opposition supported by the Board of Medicine and Surgery. As the Board of Medicine points out in that letter, they are actively involved in contingency management plans in conjunction with the CDC and the Nebraska Department of Health and Human Services to ensure processes are in place to provide continuity of care when there is an abrupt disruption to the prescriber-patient relationship. There are a number of complications that factor into prescription authority and fulfillment, including state licensure, the Department or Drug Enforcement Agency, the prescriber's enrollment with a relative payer, whether this is a commercial insurer, Medicare, or Medicaid. We understand the goal of LB 181. However, we still feel that this may create as many problems rather than solving one that we're not certain that really exists. We value our partnership with the Nebraska Pharmacists Association, and we appreciate them sharing this legislation with us before the session began. While we don't support the approach, In LB 181, we would welcome the opportunity to continue to work with them to ensure patients can safely and reliably receive their prescription medications. Thank you, and I'm here to answer questions.
Thank you for being here. Questions, committee? May I ask one?
Yes.
From 100,000 feet up. Clearly, we have two different perspectives here. Being a guy from out west, I have to ask the question, has anyone from the AMA ever been to western Nebraska? That would be somewhere west of, I don't know, Kearney. It's the spaces are far and wide out yonder.
Yes, but I don't know how long it's been.
Okay. Do you get the sense of what I'm asking? Sometimes it's just difficult, as our previous testifier indicated, where it's difficult to somehow pour the barrel of the day into the thimble of reality. And so how do you get it done? And sometimes we're shocked and dismayed to learn that our provider is no longer our provider in certain cases. And so anyway, is there any leeway for some help in those extenuating circumstances?
I think that's always a collaboration and in cooperation with each other. I would tell you that as I approach that age, which I hope that I can voluntarily retire from practice, I'm very cognizantly aware of every prescription I write or document right now as to when that expiration date is, because I want to know that I will still be in the office taking care of those patients if I am. And if not, I'm trying to make sure that those expirations are running out at a time when I think those people need to be seen and need follow-up. At my stage of my career, I'm mostly a geriatrician, which is pretty close, which is pretty much what I take. I am myself, if you want to look at that. And I recognize how often that I need to see those people, and I need to know when they need to come in, and I need adjustments. There are certain reasons I prescribe only a 30-day. I prefer everything was a 90-day prescription. There are sometimes I need a 30-day because I need those people to come back. I think there's some potential concerns that I have in that situation that my patients may not be getting that follow-up. Now, it's on me voluntarily, I hope this is never involuntary, that I retire or leave the practice, but I need to find a way to continue to manage my patients when I'm no longer there, like the last couple of weeks.
Understood. Any other questions? Thank you for being here.
Thank you.
Anyone else in opposition to LB 181? Anyone in the neutral for LB 181? If not, Senator Hansen, would you come up and close with us, please?
Well, I'll keep this short because I think they pretty much explained both things. But I think when we talk about healthcare, we always talk about best practices. Clarification and clarity is a part of that. And I think that's kind of the purpose of this bill, is to provide clarification for everyone involved, that what their role is and what they're allowed to do and not allowed to do. I think that we do that in many instances in healthcare, and I think this is just one of them, along with what 43 other states have done. This is one way that we can provide clarifications. And I know a lot of medical doctors and healthcare practitioners always do, like the previous testifier said, they do what's in the best interest of their patient until something happens. They pass away, or they have a heart attack, or they lose their license for some reason. And then who's looking out for the patient? I think this bill helps provide some clarification to allow them time to find a new provider, but also get their medications filled if they need to. So with that, I'll take any questions as best I can.
Any questions from the committee? As a person who has insured lots of doctors and medical practices for the last few decades, I can tell you that doctors are not known themselves to have stellar health. And so sometimes the cobbler's children have no shoes. I just throw that out there because sometimes these things pop up where all of a sudden your doctor's no longer there. So I would also add that there have been 6 letters from proponents, 2 letters from opponents, and I thank you so much.
Thank you for your plethora of analogies too. All right, thank you. I had to write that last one down.
Barrel of the day. Barrel of the day. Cobbler shoes.
I like your fiscal.
Mine?
Yeah, like zero.
Those are always nice.
That's a lot of people.
All right. All right, so with that, we'll open up on LB 245 and welcome Senator Walz to open.
Good morning, committee members. My name is Lynn Walz, Lynnewalz, and I represent Legislative District 15, which includes Dodge County and Valley. I'm here before you to introduce LB 245, which is a simple change, so I'm going to keep my opening very short. The bill simply changes the per diem reimbursement rate for members of the Board of Barber Examiners. The board recently changed from having their meetings over the course of 2 days to meeting for 1 day. This per diem change reflects that. Reimbursement would change from the current rate of $75 to $150. The board members are completing the same amount of work, and the bill allows them to receive the same amount of pay for the expenses they incur by doing their duties. This bill encourages government efficiency and helps ensure that those willing to serve are reimbursed fairly. Thank you for your consideration of LB 245. I'd be happy to answer any questions, but Ken Allen from the Barber Board is here to testify and will be able to answer in greater detail. Thank you.
All right. Any questions to the committee? Seeing none, thank you. I'll take anybody wishing to testify in support of LB 245.
Good morning, Chairperson Hansen and the committee. I thank you for your time on this bill and my chance to speak. I thank Senator Walz and her crew for crafting this bill. It's a very straightforward cleanup bill. What we do, as she explained, we currently pay our board members $75 per day. Okay, so, and that was on a 2-day, 1 day meeting and 1 day for examinations. So we have condensed everything into 1 day now using our money wiser. But the main reason we did that, our examinees are required to bring a live or 2 live models to the exams. It's hard to find somebody to come in on a Monday. Our meetings were on Sunday, exams on Monday. To try to find somebody to come in on a Monday, working class people. So our board members heard their cries. They voted July of 2021 to change it to a 1-day meeting, just to try it out, see how it worked. It worked amazing. So we were able to get the examinees their models, if you will, live models to do their examination, complete their examination, and we were able to get the meeting in 1 day, and then they get to go home and spend the rest of the weekend. Sunday, Monday is our weekend, so they get to spend their Monday at home with their families. So this bill fulfills everything that was needed. Now, so the board members were curious, why do we only get half the pay for doing the same work we used to do? So this was why this bill was crafted. And it's also hard to find board members. I don't know if you've ever worked in that department, but board members don't just come and run into your door looking to be a board member. We have to do some recruiting. We try to screen the best members for the best job. That being said, if you look at the fiscal note, my side of the fiscal note shows a 0. However, budgeting wrote in there if we have a 5th meeting or a 6th meeting, because currently we do 4 meetings per year, okay? So that's what we have to have. If we happen to have a 5th one, which I haven't seen since I've been here, and I've been here almost 10 years, that is why that's in there. But like I say, I have never seen that 5th meeting. If I have, it wasn't an issue. It was a non-issue thing. So that being said, straightforward, we would reiterate, combine 2 days pay into 1 day's work, and it's still the same duties. We would ask you to consider this bill, push it out to consent calendar, and I'd be happy to answer any questions you may have.
Any questions, committee? All right. Seeing none, you're off the hook.
Thank you, senators.
Thank you. Anybody else wishing to testify in support of LB 245? Okay, is there anybody wishing to testify in opposition to LB 245? Is there anybody wishing to testify in a neutral capacity? Seeing none, Senator Walz waives closing. And that will close the hearing for LB 245. And last but not least, we'll open on LB 261 and welcome Senator Riepe to open.
Thank you, Chairman Hansen, and good afternoon, members of the Health and Human Services Committee. For the record, my name is Merv Riepe. It's MERV RIEPE, and I represent the 12th District, which consists of Southwest Omaha and the city of Ralston. Before I begin, I'd like to comment that an actor likes to play in front of a full house, and obviously I don't have that today, but I appreciate the opportunity to be here. I have introduced LB 261 on behalf of the Nebraska Funeral Directors Association. Prior to becoming a license in the field of mortuary science, a candidate must complete, among other requirements, a 12-month apprenticeship program. Any revised statute 38-1416 currently provides that a candidate may choose to complete the apprenticeship program requirement in 2 6-month blocks. This split approach allows a candidate to begin to work in the field immediately upon granted an apprenticeship license. While engaged in this first 6 months apprenticeship period, the change in LB 261 will clearly articulate the candidate is permitted to concurrently engage in the School of Mortuary Science coursework, working towards completion of the coursework as one works through the first 6 months apprenticeship program. LB 261 is intended to accomplish 2 primary goals. First, as with most other professions and industries in the state, there is a shortage of individuals engaged in and working through the funeral directing education process. It is becoming more difficult to find qualified licensed individuals willing to remain in or move into rural parts of our state to provide what is a very necessary service to communities. Funeral directors from across the state, including the State Board of Funeral Directors and Embalming, view this legislation as another piece to removing unnecessary bbariers to enter into the funeral directing profession. Second, the world modernizes and continues to move forward, providing more efficient, convenient ways of meeting everyday needs and requirements. In the world of education and training, online courses work has become more widely accepted and very popular. And as such, online mortuary science degrees are becoming much more common. The change provided for in LB 261 is intended to expressly provide in statute an accommodation for concurrent work on both a mortuary science degree and completion of the required 12-month apprenticeship program. I would like to note there is no fiscal note associated with LB 261, and I thank you for your time and attention, and I will be happy to the best of my ability to answer questions. I will also, following me, will be a funeral director who will address specific questions relating to the practice of mortuary science. Thank you, Mr. Chairman.
Thank you. Are there any questions from the committee? Seeing none, thank you very much.
Thank you.
And we will take anyone who wishes to testify in support.
Thank you, Senator Riepe. Committee, my name is Paul Seeger, Paulseger. Wanted to address the LB 261. Usually the funeral service industry, we like to be behind times on everything. And with the online schooling, we want to be kind of with it and recognize that the online schooling is a major part of it now. I personally have 3 kids that are in online mortuary school that work with me every day. So I proctor them, teach them kind of the ways, and then they go to school to learn how to take the test to pass the national board. Purpose of this bill today is that it gives us an opportunity to kind of weed out kids that maybe, there are some kids that go to mortuary school that don't always have never experienced it and been in a funeral home. So this gives us an opportunity to let these people in. They can serve the apprenticeship their first 6 months after they have completed 20 hours per the state requirements of the 40 that were just redone. And then that gives them an opportunity to see if it's going to work out for them before they go through all the schooling. They go through everything, 12-month apprenticeship, and it just doesn't work. Then that puts us behind on trying to fill positions on getting workers that actually want to do funeral service. Not everybody wants to work long hours, weekends, all that kind of stuff. So that gives us an opportunity to get these kids in, and then it gives them a 6-month head start once they have completed school. So then we can get them in the workforce sooner. So that was the main point of this bill.
Okay, any questions from the committee? Yes, Senator Ballard.
Thank you, Chair Hansen. Thank you for being here. Do you have a hard time finding apprentice for funeral directors?
Yes.
Okay.
It's tough. Now I think so I'm fortunate because I'm here in Lincoln that people want to be in the city. We've heard all day people talking about western part of the state, further out west. I grew up in the north central part of the state, and to get somebody to be like, okay, I want you to go here is very tough. I think you can all recognize that. This kind of, we can take this, we can get those homegrown kids that may be interested, keep them home, working with that person there, do the online schooling if they so choose, or they can go to an outside school and do the same thing. And then get them back into those rural communities. We kind of feel this is, along with our examining board, kind of feel this is the easier solution to get those people to go to the western parts of the state. If they're already there, they like it there. If they could do all the schooling and still work with the people and be licensed and do everything they need to do, I think it's a good step in the right direction for that.
Thank you.
I discussed this with one of my really good friends, Darren Rapp,
He's a good friend of mine.
Yeah,
as well. Yep.
Yeah. Okay, well, I'm sorry to hear that. So, but no, he's the same thing that you just expressed. Like, there is a big need for people in your profession, and they're having a hard time finding people. And he's the same thing he said. Sometimes you have people like get in there, and they take the schooling, and they do the apprenticeship, and they find out they don't like it.
Right.
And I had somebody in my class that went out to chiropractic school. They went through a year and a half of school, and then they finally found out they don't like to touch people. And so so they quit. And so you never know until they actually get started. So I think it's a huge thing, and getting them out there sooner. So
yeah, I was in mortuary school with people that had never set foot in a funeral home before. And so they passed the national boards, they did all that, and then they went their first 6 months, and they're like, I can't do this. And they were out. And they spent all that time getting all that education to just turn around and go do something else.
yeah, so and it makes it tough with people who currently are working because they think they might come work for them or
Correct.
something else. And then they're out.
They put all their time and energy into them. And
Okay, well, good. Well, thank you for your testimony.
Thank you.
Appreciate it. Anybody else wishing to testify in support of LB 261? All right, anybody wishing to testify in opposition to LB 261? Is there anybody wishing to testify in a neutral capacity? All right, seeing that, Senator Riepe, do you wish to close? He waives closing. And with that, that will close our hearing for LB 261, and we'll close our hearings in the Health and Human Services Committee for the morning.